Good morning, chairpersons, friends, seniors, and delegates, and congrats to organizers. I will be presenting the Dolenc approach for complex skull-based lesions. And briefly about myself, I did my MBBS and MCH from All India Institute of Medical Sciences, New Delhi, AIMS, and microsurgery training is at AIMS. And briefly, I did endovascular fellowship from outside. And currently, I'm working in Jaipur. It's 550 bedded hospital, private setup, and we're well equipped to handle microsurgical and endovascular aspects of the neurosurgery. And when we talk about cavernous sinus, the knowledge comes from almost 2000 years older, and it has been passed from generation to generation like Olympic torch. And in 21st century today, it's possible that we can explore it microsurgically, endoscopically, and endovascularly also. Despite that, this area still remains the jewel box, and particularly in this image, I want to focus on the superior orbital fissure. It's not a foramen, it's the gap between two bones, and it forms the embryological basis for these approaches because the outer layer of dura interacts with the bone. If the bone is absent, that layer of dura is not so well defined. That's why the peeling is possible at that area. And Dolenc extra in there is no limit for bony work in skull base, and but the anterior clinoid process, this bone makes it special because it is surrounded by the critical structures, optic nerve, carotid, and oculomotor nerve, separated by the thin layer of dura. And after removing it, the whole anterior skull base unlocks. So first, I will start with the vascular case, and it's a giant aneurysm, 60-year-old lady. There was no comorbidities, and it was ruptured. That's why we did not want to give the antiplatelets, so chose for the surgery. 3D vaso-angio showed that the normal vessel can be accessed only after removal of the clinoid process. So we prepared for both clip reconstruction if clinoidectomy is possible, and high flow bypass if clinoidectomy cannot be performed. And cervical exposure was done. And this comes from my endovascular knowledge that this device, you just have to put the cannula into the ICA and turn the three-way straight, so it will suck the blood if from the aneurysm if the aneurysm has been exposed 360 degree, and can be done clip reconstruction. So there is a video. This is not edited video, just fast forwarded because I wanted to demonstrate all the steps. The clinoid process has been drilled, and all the three attachment, laterally sphenoid, laser wing of sphenoid, medially plenum sphenoid, and inferiorly the optic strut. Despite that, I spent almost half hour to remove this clinoid process because you cannot just pull. There is a slight oozing from the venous plexus, but just spend your time and remove the clinoid precisely when you are in 100% control. Once the extradural clinoidectomy is done. And why it cannot be done intradurally in this case? Because when I opened the dura, there was an aneurysm. You cannot see the clinoid because it was hidden. That knowledge we had from the NGO. The routine microsurgical principles were performed to further expose the aneurysm. And aneurysm was clipped, supraclinoid ICA was preserved. And the lady had transient third nerve palsy, but the post-op angio showed no residual aneurysm, and that improved over the 3 weeks. And at 2 years of follow-up, she is living independently without any antiplatelets. Second situation, the most common cavernous sinus invasion is by pituitary adenoma, and post-COVID we have seen the few cases by the infections, fungal. This lady was operated first in 2023 and did not do any MRI after surgery until she felt unconscious in 2021. When she came to us, this was the picture. The growth was laterally, paracellular compartment. So we gave mannitol steroids. She regained a little bit consciousness. Her vision was gone, and there was hemiparesis and panhypopituitarism during the workup. So extradural approach, the tumor was removed in 3 segments: cavernous sinus segment, intradural, and combined. So this was the final picture after removal of the tumor. All the structures have been defined. The peeling is possible easily because the supraorbital fissure, where there's a gap. So the 2 layers of bone are 2 layers of dura are easily separable, and unroofing of optic canal is done. This part is similar to any other clinoidectomy. And once this exposure is done, the Parkinson's triangle was used to remove the tumor. And the essence of the extradural approaches, these transcutaneous approaches, is that until you open the dura, there should be no sign of that you have done something extradurally. That is the essence. If your brain become confused, there is bleeding inside, then there is no superiority of these approaches. The there is a incidental aneurysm. Can you see? These might be the case that you develop the SAH in your cases. This aneurysm we just wrapped with the dura because it was very small. And once the sufficient part of tumor was removed, the combined extradural and intradural approaches were performed. And the third nerve is the main guide in this dissection because in this case, we exposed from supraorbital fissure to the cavernous sinus to the prepontine cistern. The third nerve guided our dissection. All the perforators, this is not possible endoscopically. Even if somebody says that we can do, but I think these perforators around these the basal cisterns cannot be preserved. So this lady and woke up on the same day, and she again don't want to do any MRI. But we have convinced her she is living independently with completely neurologically intact and following her with the CT. The third case, cavernous sinus tumors, most commonly meningiomas and schwannomas. This lady, again, she came to us with the proptosis and pupils are dilated. There was third nerve palsy, and the diagnosis was in 2019, and she was in reproductive age group. That's why they did not choose for surgery because of that it can hamper. Either it could be life-threatening. That's why. And in 2023, when she came, it was even more life-threatening than before. But the family was satisfied. They gave me full free hand that you do whatever you want to do, just remove this tumor because her family aspects were settled. So, and when you look at the bone window, it looks very tempting that our bone work has been done, but it's not so. I will show it in my video.
This time is...
Yeah, just 1 minute. Last case, this is the last case. So, this is a standard approach. See, clinoid is buried inside the optic nerve, and you cannot pull. And this dissection to this level, see, optic nerve, extracanalular optic nerve has been exposed. The clinoid is dissected from that and removed. And the routine, last thing which I want to, optic nerve was decompressed 360 degree, and gel foam which I kept from extradurally is visible. And this space is possible because I have done so much of things extradurally. This is done, and at biopsy was schwannoma. The best thing was that her pupils were reactive. It was become symmetric. Third nerve palsy recovery was partial, but pupils became reactive. And at 1 year follow-up, she is doing her job independently. And cavernous sinus mastery doesn't come from the tumors or these vascular lesions. I feel that if in these situations at 2 a.m. in the night, if you can perform it perfectly, then I feel this case was the most rewarding among all these cases. I could not do the recording because of the emergency. If we do not use the recording microscope. And take-home message is that apart from individualizing and preserving all the structures, the superiority of extradural approaches lies in that how much less damage you do intradurally. If you do extradurally and there is temporal lobe contusion, there is no superiority. And this is the AI generative image of Dolenc's approach. I have done in various formats. It points to the pinpoint that if you are pinpoint that what is your target, then you can approach these lesions.
Okay, thank you very much for the very nice talk. And Dr. Anil. May I call Dr. Ashok Nirala? He would be talking on MBD in trigeminal